Okay, the theme of my talk today is going to be about the role of the drug-coated balloons today and tomorrow. So just to clarify, so far regarding the guidelines, the optimal vascular access stenosis treatment is balloon angioplasty and high-pressure balloon angioplasty is needed. Both the KDOQI and the ESVS guidelines do not provide any recommendations regarding drug-coated balloon use in vascular access, and this is mainly due to the fact that both the KDOQI and the ESVS guidelines were published before the big DCB trial. So the KDOQI were published in 2019 and the ESVS guidelines in 2018. What is our main problem? The problem is stenosis in vascular access, a stenosis that we need to repair immediately because the patient needs to go back to dialysis, but unfortunately wrist stenosis will occur, and then we will need to repair this wrist stenosis again. What is responsible for stenosis and what is the histopathology? So there are three main factors leading to vascular access stenosis. The first one is the vascular access creation itself, which is a dramatic and traumatic event with fibrosis, incisions, sutures, etc. Then the vascular access is cannulated during dialysis with 2 needles 3 times a week in most of the cases for 4 hours. And the other is that the inherent problems of end-stage kidney disease that have caused oxidative stress and hypoxia to the endothelium. So all these factors cause inflammation and endothelial dysfunction that leads to venous neointimal hyperplasia. So this is the key words, venous neointimal hyperplasia. And this hyperplasia is mainly myofibroblasts and differentiated contractile smooth muscle cells that they produce an excessive extracellular matrix. So these cells, together with the matrix, they produce this fibromuscular aggressive thickening of the vascular wall, and this is venous neointimal hyperplasia. So in this frame of stenosis and wrist stenosis, we need two things. The first one is that we need what the cardiologist mentioned as immediate lumen gain. So we need to fix the vessel. We need to fix the flow because the patient needs to go immediately back to dialysis. And the second thing is that we need an adjunctive treatment that will increase the period between stenosis and wrist stenosis. So a few things. Wrist stenosis to occur needs cells that come from the outer vascular layers, neighboring tissues, and circulation. And like we said, they accumulate, they divide, and they produce this extracellular matrix. So if we would have a cytotoxic factor that could attack these cells, it will stop these things, and it will also slow down the process of wrist stenosis. And to that end, and up to date, this cytotoxic factor is paclitaxel. Let's see a few things. How did it all start with paclitaxel in vascular access, drug-coated balloons in vascular access? So the first study came from our department in Patras. It was a randomized controlled trial, drug-coated balloons versus PTA, 40 patients with fistulas and grafts. And at 1 year, the target lesion primary patency was significantly better for drug-coated balloons. The interesting thing is that when we did a subgroup analysis for AVGs and AVFs, we found out that in the subgroup of grafts, this signal was there. There was a significant difference in favor of drug-coated balloons, but this did not happen in fistulas. So we were wondering whether this is because drug-coated balloons are not working in fistulas, or the number of cases, 7 in each group, was small. That's why we performed a second randomized controlled trial only for fistulas, when we saw that the target lesion revascularization-free survival was significantly better for the drug-coated balloons, but also the access circuit primary patency was significantly better in this case. Where do we stand today? We have a number of studies. We have a vast number of cases. So you can see there are more than 34 studies, and more than 1,900 patients in these studies have received a drug-coated balloon treatment. And so far, we have 7 devices. One of them with a high number of cases is the Aperto from Cardianovum. what have we learned from all these studies? What are the important things we learned? So from a global multi-center prospective registry from Dr. Kanapatidis and colleagues, which was 320 patients, endpoint at 6 months, it was an all-comer study, so central veins, grafts, fistulas, everything. What we found out is that it is important that we performed a pre-dilation. So in the cases that no pre-dilation was performed, the results were worse. And the second thing is that when the drug-coated balloon was inflated for more than 120 seconds, means more than 20 minutes, the results were significantly better as well. So another important thing is how we perform pre-dilation and how we make sure that we cover with our drug-coated balloon the pre-dilated area. So you see here initial stenosis there that is that receives vessel preparation with a high pressure balloon 7/40. You see the results, less than 30% residual stenosis. So then we introduced a drug-coated balloon 7/60. So the high pressure balloon was a 7/40. This is a 7/60. And now I will overlay for you the two images, and the two red arrows show where the drug-coated balloon is, and here is where the high pressure balloon is. So you have to make sure that you will cover the vessel preparation treated area with your drug-coated balloon to the full length and an extra half a centimeter on its edge. Another important thing is that when you have, like in this case, you have a stenosis at the cannulation zone, we treated with a high pressure balloon 7/80. So we had to use a longer drug-coated balloon, which was not available at our department at that time. So what we did is we used two drug-coated balloons, a 7/40 and a 7/60. So in case you use two drug-coated balloons, you have to make sure, and you can see that in this overlay, that you cover the in-between segment enough so there is no geographic miss there as well. And this is the final outcome. Another interesting finding came from another study when we investigated what are the results of consecutive treatments. And what we came up with is that there was a significant difference in favor of a second treatment with a drug-coated balloon. So you can see that the first intervention, the post-intervention primary patency was 269 days, wherein the second intervention was 520. So another thing that you can get an augmented result theoretically with the second consecutive treatment. We also have studies on central venous stenosis. There are 7 studies, 200 patients. So we perform, it's a work in progress, a meta-analysis on these studies. Some of them are cohorts from other bigger studies. And what we came up with is that safety was 100%, and the target lesion primary patency at 12 months was 35.61%. From all the studies, and I'm talking about central venous stenosis. A very interesting finding came from this study, which was a multi-center one, 86 patients, 17 physicians involved, 11 centers participating across Europe. You can see the target lesion primary patency, the access circuit survival up to 2 years, and the patient survival. They are quite good. The most interesting finding is when we did the Cox regression analysis, we found that the only independent factor that would positively influence the primary outcome measure of target lesion primary patency was the balloon diameter. So an increase by 1 millimeter of balloon diameter improved the target lesion primary patency by 29%. So that's a third very interesting finding. There's also an excellent study from one of my friends and colleagues who is with us in the panel today, Dr. Shaverdian, who was the first who actually tested the drug-coated balloons in percutaneous fistula, which he also showed that that significantly more patients require reintervention with a PTA compared to drug-coated balloon groups. in this retrospective, single-center retrospective analysis, and I'm sure he could give you an insight to this study as well. What about safety? There are 3 studies with 1, 2, and 3 year outcomes that show no mortality signal in all in these studies, and although they were also with different drug-coated balloons. So to summarize, procedural characteristics for drug-coated balloons are very important. So vessel preparation, time of inflation, and balloon diameter. Drug-coated balloons are drug delivery devices. They are not angioplasty devices, so you have to prepare the vessel, you have to do the mechanical work with a high-pressure balloon and then use your drug-coated balloon. Repeated interventions with drug-coated balloons may have better results. Drug-coated balloons may have their own central veins, and they may have significantly better results both in surgical and percutaneous fistulas. Fistulas behave better than grafts, and there is no mortality signal for drug-coated balloons in vascular access. What are the problems? The problems is that not all drug-coated balloons are the same. We have different paclitaxel concentrations, we have different excipients, and not all lesions are the same. So like you wouldn't compare the results in the iliacs or the SFA or the below the knee lesions in PAD. You wouldn't do that with different circuits, with different sites, for example, the cephalic arch, the outflow veins, the central veins. There are different lesions like de novo and restenotic, and there are also different types of lesions like fibrotic or hypoplastic lesions, or although I have an asterisk there because I'm not a really big fan of this differentiation. And last but not least, not all patients are the same. So we have different geographies, and in these geographies, we have different ways of performing dialysis. What does the future hold, and what are the unmet needs in this field? We need more studies. We need, ideally, we would like to have a patient-level data meta-analysis so we can pull all this data together and maybe come up with specific lesion site endpoints. So, or we can have lesion-specific studies, like, for example, the cephalic arch or the venous graft anastomosis, etc. And definitely we need more central venous stenosis studies. The new drugs on drug-coated balloons, which are rapamycin derivatives, the Olimus family, will need a lot of time, minimum 3 or even more years to provide valid data information comparable to the paclitaxel drug-coated balloons. And the new medical device regulation in Europe is a major obstacle for further investigation. So overall, drug-coated balloons are safe and effective in vascular access. A lot of lessons have been learned during this 15-year period, not only regarding drug-coated balloons, but also on how to improve PKA results. So one of the major advancements with drug-coated balloons is that we focused on how to perform proper balloon angioplasty. And as vascular access creation has better results in experienced hands, the same stands for restenosis treatment and drug-coated balloon use. So operators should understand the indication and limitations of drug-coated balloons as for every device. Thank you for your attention.